authentic and caring residents willing to do the work for growth and change. Over these years, there have been positive results and medical evidence that will be summarized by the investigators in just a moment. Thank you to the Heart Healthy Lenoir Community Advisory Committee, our local residents who have faithfully met regularly with interest and with input. The Lenoir County Alliance for a Healthy Community has been an integral partner of the project and assisted in so many ways. Thank you for your collective and individual work and for members being here with us this afternoon. It has been said, what you seek is seeking you. And that is true of a community too. The lessons learned and the impact carried forward from the Heart Healthy Lenoir project reveals true strengths and potential in our community. The investment of this effort over these 5 years has given us knowledge and can be a catalyst for more growth. We seek health improvement in Lenoir County, and the health status of our residents will require us to seek further. Again, warm welcome to everyone, and thank you for being with us today. I'm happy to hand over to Dr. Alice Ammerman, who is the Director of the Center for Health Promotion and Disease Prevention, a professor in the Department of Nutrition at the Gillings School of Global Public Health, and the Principal Investigator for Heart Healthy Lenoir. But as Beverly Garcia says, we'll just call her Alice.
We encourage all of you to move in towards the center as much as you can to see the slides. We may scoot this podium over a little bit so we don't block it. I tell my students, in terms of the call me Alice comment, that if they have to call me Dr. Ammerman, they can, that I prefer Alice, but I draw the line at Big Al. Notice I'm a little on the tall side. So we are delighted to be here and that so many of you have come. I just want to take a little poll. How many of you have been to one of the expos, the Living the Good Life, and seen Heart Healthy Lenoir there? Raise your hand. Okay, how many of you have been to one of the restaurants involved with the program and seen a table tent or about reading a newspaper article that says something about? Newspaper article, is this better?
Yes,
that says something about Heart Healthy Lenoir. Right. Now this is the real test. How many of you have tried our Heart Healthy Lenoir barbecue or hush puppies? All right, a few people. We've got the recipes over here. So, again, thank you so much to all of you who have participated with us. We don't want this to be seen as the end of this project. It is the end of some funding, but we are trying hard to continue to work together, and we want to bring together the ideas and really keep this going. And I think Constance really has some powerful words in that regard, that we really want to make an influence on health in the community. So I'm just going to get us launched a little bit. Let's see.
Cassie.
Oh, Cassie. Okay, I was looking for a button. Okay, so just again to acknowledge our research team partners, in addition to UNC-Chapel, very important partners from East Carolina, and you'll hear from Skip in just a minute. And then, of course, we started in the very beginning with the Lenoir County Alliance for a Healthy Community, so we met with Constance and Joey before we even wrote the grant to find out how to get this rolling. And then from that, we formed the Heart Healthy Lenoir Community Advisory Committee. If you're on that group, could you raise your hand? A lot of really important contributors to that. Thank you. And then many Lenoir County organizations and individuals who have contributed to all of this. And it's funded by the Heart, Lung, and Blood Institute, which is part of NIH, and we are really honored to have Peter Kaufman here somewhere. I think he raised his hand, who was instrumental in that effort. So I'm going to let Skip say a little bit about why we're doing this project here in Lenoir County.
Again, I'm Skip Cummings. I'm from East Carolina University. I have my purple and gold on, so you can tell where I'm from. It is great. It's fantastic to be here with you today. And more than anything else, what I want to tell you is thank you. I want to tell you thank you for opening your doors and allowing us to come and be a part of your community over the last 5 years. We have learned much more from you and with you than we have ever learned sitting in our own offices, staring at a computer. You guys have taught us so much, and we're excited about the things we've discovered together, because we believe those are things that can help us really make a difference in cardiovascular disease going forward. So thank you again for your care for us. I want to make sure you understand, as Alice shared with you, this is a project funded by the Heart, Lung, and Blood Institute, but this is part of a larger effort with grantees, folks that are funded from all around the country. We've had the privilege of being together with many of those folks over the last couple of days, and the neat things that you helped to teach us, we were able to share with people from all over the country over the last couple of days, and they are excited about some of the neat things that are happening. So you see here some of the other places. Cassie? Why cardiovascular disease, and specifically cardiovascular disparities? So we're particularly interested in trying to understand why there are differences in the rate of cardiovascular disease and cardiovascular death, particularly in places like Eastern North Carolina. As we look at it, we're thinking about this in terms of inequality in rates, in incidence, mortality rates, etc. When we look at this, the rates are clearly, as Constance said, higher here in Lenoir County. And we're particularly interested in understanding why these rates may differ as a function of race or ethnicity, as a function of income levels, as a function of literacy level. And really our goal throughout this whole project has been to try to understand ways that we can narrow that gap that exists, particularly by race and income here in Lenoir County. And we've made good progress. You'll hear some of that tonight. Again, why Lenoir County? You can see in this slide. You may not understand this, but if you look at where cardiovascular disease, and in particular stroke, is a problem in the United States, the southeastern United States bears the burden of that. We call that the stroke belt, where rates are about 50% higher than the rest of the nation. And particularly right along the eastern coastal plain there's an area that we call the buckle of the stroke belt, if you will, where the rates are even twice as high as national rates. So that includes Lenoir County. Okay? But it's not just about numbers. It's not just about numbers. Unfortunately, cardiovascular disease robs people of productive life years. It happens all too early in the life of some individuals. So it's not just about numbers, it's about caring about what happens in the community and leading to a productive community. And so we're excited for the work that we've been able to do. The challenges, again, Constance alluded to this. These give you some of the idea of how Lenoir County compares to other counties in North Carolina. And these are rankings that have been available nationally for Lenoir County. So out of 100 counties, Lenoir County is historically ranked 90th out of 100. Number 1 being the best, 100 being the worst. So number 90 out of 100 in terms of morbidity and mortality, that's disease and death associated with cardiovascular disease and other things. And number 70 in terms of health factors. So again, number 70 out of 100 in terms of health behaviors. So these are one of the reasons that we chose Lenoir County, but clearly not just because of that. Okay? As Constance alluded to, you have tremendous assets here. We would not have chosen to be here if there wasn't great potential for change. So thank you very much for the time and the opportunity, and I'm going to turn it back to Alice.
So speaking of assets, Skip asked what he could do, and I gave him all the tough slides, one's about the bad news. So I I get to talk about the good news. And so there are amazing assets. This project would never have gone anywhere without all the support from the county here. I mentioned the County Alliance for a Healthier Community, very collaborative community hospital, health department, Joey Huff, Hospital Constance, and Cooperative Extension, Tammy Kelly. Just every time we turned around, we were calling on them for something. You'll hear more about several primary care practices that we work with, including a community health center. Very strong and supportive Chamber of Commerce, thanks to Laura Lee Sylvester for all of her help. A number of restaurant owners, you'll hear more about them too, who collaborated with us on our project. And just a lot of entrepreneurial support and creative ideas from the community college and elsewhere, and for taking us into the Kingston Enterprise Center where we had our office space, thanks to Adrian there for his support. Just a wonderful spirit of collaboration here. So just quickly, and you'll hear more about each project, we set aside a whole year to really learn about the community, so we didn't just come in kind of guns blazing, not knowing what we were doing. And then years two to four, we conducted the studies, and now we're in year 5 where we're analyzing the findings and reporting on them, and we want to share those back with you. So we formed a community advisory committee I mentioned earlier, who met regularly with us, gave us amazingly helpful advice, and really steered us in the right direction to make sure that our research was really meeting the needs and was sensitive to the important culture and aspects of the community. It's represented many, many groups: public health, medical, business, policy, faith community. Okay. And this process of learning about Lenoir County, we did a lot of talking. We talked with patients who might be participants. We talked to doctors in clinics to understand what would help them help their patients more effectively. Just overall looking at what we could do to better promote health. We tried to really understand the culture of food, physical activity, and health. What do people like to eat? What do they like to do to be active? What don't they like? Learning more about really the strengths and challenges as we've been talking about. And then just taking all of this and applying it to developing a really comprehensive program. So I'm going to turn it over to another ECU colleague and a former student of mine who I'm very proud of, Stephanie Pitts.
So much. So I'm really excited to get to be here and share some of our community-wide efforts to promote health in Lenoir County. I don't know if y'all have noticed this beautiful vine over here, but a lot of the photos and community events that have taken place over the years are sort of displayed here on this vine. And it is a vine, so it'll continue growing, hopefully, as we continue to add and move forward. So I told the team that I couldn't present these slides, and I know you've heard it over and over again, but this really has been a community effort, and a lot of people have really done a lot of work and facilitated the work. So I wanted to just give a shout out to our community advisory committee again, our restaurant owners, who a lot of the food is featured here today, and agencies like the school system here, Cooperative Extension, the hospital, Chamber of Commerce, the health department. So many different entities and agencies have really pushed this work forward, as well as the newspapers and elected officials and everyone here in this room who is a champion for health. So we just thank so many people. The first community-wide event I'm going to talk about is the Barbecue Festival, which is actually coming up on April 30th, so I wanted to give a shout out for that. You can see 2 of our team members here serving the Heart Healthy barbecue. Yes, you can make barbecue heart healthy, as well as Heart Healthy hush puppies, and I think the recipes are over on the table if you're interested. This is the Living the Good Life Expo at the mall here, and we've participated in that for at least 3, maybe 4 years. And this past year, there was Heart Healthy Trivia. There were door prizes and incentives for answering the questions correctly, as well as a taste test of roasted vegetables. And I think that recipe is also on the table if you're interested. And we had the privilege of partnering with a lot of area restaurants. You can see them listed here: Christopher's, Chick-fil-A, Frank Street Deli, San Juan, 4 of the Subways, and the Lighthouse. And so we really worked with them to promote healthy options at their restaurants. And last but not least is the Lenoir County Childhood Obesity Prevention Task Force. And this was really a grassroots effort from people who were interested in preventing pediatric obesity, a pediatric nurse, just a lot of people across the community, the schools, a county commissioner, were all involved in starting this effort and have kept it moving forward. And so some of the positive things that have come from that have been walking trails at schools as well as community gardens at schools. So we're really thankful for those efforts as well. So now I'll turn it over to Jackie, who's going to talk about high blood pressure study.
I'm going to try. Thank you very much. I'm going to see if I can come over here. If more people can see the slides this way, of course I won't be able to. Is that better? Okay, I was sitting over there, I couldn't see a whole lot, so I'm going to try this and see how it goes. All right, and Cassie, you're moving the slides? Is that how this is working? Great, okay, click. All right, so I'm Jackie Halliday, I'm at UNC, and I got to participate in the part of this study that was in your doctor's offices. So you'll recognize Pink Hill Medical, Kinston Community Health Center, and multiple others from around here that we worked to do very closely with the practices to say, can we actually get people's blood pressure lower? Can we come up with a system as a community, that first year that Alice was talking about, that we think will work here? Kind of a big bucket of stuff that can work here so that we can help people's blood pressure get lower. Specifically, what I'm going to show you today is the people who already had high blood pressure. Okay, so people who already came in really high, can we help them get lower? Next slide. All right, so help people who have high blood pressure get it lower. How are we going to do that? Well, we tried to do, and we did successfully, some quality improvement work with the practices. In the practices, they came and met us at events like this to do some work, but we also went right to the practices, sat down with the staff, and even the computer people to say, what can we really do to make things better? The people in this study, and about 525 of them, you'll see in a second, also got a health coach who called them on the phone and encouraged them to take their medicines. I'm seeing some heads shaking, good, okay. And used a home blood pressure monitor, wrote those numbers down, brought those numbers back into their doctors and said, okay, how are we doing? Is there something different we should do now? So these guys made the phone calls and really helped folks use their blood pressure monitors more consistently. Next slide. So this is getting a little bit of data, but it's just numbers and they're fun, and I'll make it kind of easy. So we had, among these 6 practices actually that participated, 525 patients. They were seen 5 times. We did a baseline visit, checked their blood pressure really carefully, asked them lots of questions, and then kind of hooked them up with their phone coach and their blood pressure monitor. We brought them back at 6 months, and we did some of those things again, specifically the blood pressure. We saw them at a year. This is a long time. And then 18 months, and then 2 years. So we got to see these people over time and see how they were doing with their blood pressure. Everybody got the monitor and the coach, and then again, we really worked with the practices to say, what should you do with every patient with hypertension when they come in? What needs to be addressed? How deeply do you need to go to find out if they're able to take those medicines, able to afford those medicines, able to use that crazy blood pressure cuff you gave me? You know, really work with them so that every time they came and saw their regular doctor, nurse practitioner, physician assistant, nurses, they could address these things each time. So that's really quality improvement. So this intervention is really this big bucket of things. We wanted the practices to function more like teams. So the people at the front desk or your person checking your blood pressure might already be teaching you and asking you about your medicines and how you're able to afford them and whatnot. Again, this very popular use of home blood pressure monitors, this making sure that everybody is taken care of at each visit, and then the phone coaching. So the numbers I'm going to show you, it's about, did this bucket of stuff help people get their blood pressure lower? And I want to, and let's see, next slide, because I want to be very clear what number I'm looking at. The numbers you're going to see here are about the systolic blood pressure. That's this pressure in the vessels that run around your body while the heart's working really hard. So when the heart, the thick muscle of the heart crunches down and works hard, there's pressure in blood vessels. That's the systolic blood pressure. That's the top number when you go in to see your provider or measure this on your own. So you're only going to see systolic blood pressure numbers today. Okay. So the question that we were charged with is, can we get everybody's blood pressure lower? But then, as Skip mentioned, can we also do something where if our African American patients came in starting a little higher than the whites, which we do know nationally is the usual thing, African Americans are a little higher, can we over time get everybody to the better place? Can we narrow this disparity or narrow this gap? See the gap, and can we bring it down over time? Okay, next slide. I wanted to tell you just a little bit, realistically, not every single person could come into every visit. So the results you'll see is everybody that was able to make it into one of these visits. And again, I'm going to just show you, did the average systolic blood pressure, that top number, come down, and then did we see it at 1 year, and how was that doing 2 years later? Okay, next slide. So here's the comparison. The numbers I'm going to show you are from here to here, which is just baseline to 1 year. Okay? Thank you. Is that better too? Okay, next slide. And yay, it worked. So among those who kind of came in overall, and then they got the big bucket of intervention, the average top number was 139, and 1 year later was 133. This is actually really significant. This is the kind of thing that we can really be happy about and feel like we will have fewer strokes. We will have fewer heart attacks. We will have fewer of these kind of bad outcomes if we can continue this kind of work going forward. So everybody, we actually lowered it by 5, and that's actually really good. Next slide. Okay, so purple is just, okay, so here's the folks that were African American. And yay, it worked there too. So over 1 year time, we were able to get the African Americans that were in our study to also have a very nice reduction. The next slide, thank you, is our white patients. Again, came down nicely, so it seemed to work. Did seem to come down maybe a little bit more in the whites. Next slide. And so did we see a narrowing of the disparities? Well, not really, but it's not really significantly different. So when we apply our statistics, everybody got a little better, but we didn't necessarily narrow that disparity like we wanted to, but we're pretty happy just to see blood pressure lower. But this effect did not necessarily happen. Next slide. So, I feel like one was lost. Okay. Is there another slide on this, Cassie? Okay, that's fine. So over 1 year, it was able to come down in blacks, it was able to come down in whites. So yes, they went down, not in this kind of statistically significant way where we're able to reduce that gap, but we're pretty happy to see people's blood pressures lower, as I said. Now, next slide. This is probably what I was looking for. Okay. And I don't, because of time, I just want you to know that we saw the same thing at 2 years. So that blood pressure was able to come down and stay down into that second year, which is extremely good news. Okay, now I want to show you this because this is more how maybe the health department and other folks look at blood pressure. There's other ways to look at this. Some people really want to look at if your people with high blood pressure were able to get it under control. Meaning, were they able to get that top number under 140? And what percentage of your patients who have high blood pressure can get that down? And so I wanted to show you this because this is actually really fun. Next slide. All right, so I know busy slide. This is the whites, this is overall, this is African Americans. At the beginning of the study, about 55% of folks had it under that number, had it under control. And then by the end of the study, 70s and above have it under control. And this very important line is a national goal for communities to get above actually 61.2%. So this community, using this data, has actually gotten and reached Healthy People 2020 goals, which is phenomenal. Next slide. So, yes, it worked. Improvements in blood pressure were noted in the first year. The second year it was maintained. Let's Tell, I got balloons going for Let's Tell Healthy People 2020 about it. And the next steps, there's a lot. Dr. Little's here somewhere. He goes, when are you going to publish the paper? I was like, whoa, whoa, whoa. We'll get there. That's what's next. And we'll certainly be publishing things and sharing it with you. And I think Tom is next.
So I just want to say that I have done many studies over many years, and I've never had the opportunity to come back and present results to study participants. So I'm not going to ask you in the audience who are participants to raise your hand. I know many of you are. I just want to thank you for this privilege of coming back and sharing our results. And thank you again for participating. I also want to take a second to recognize our staff, both in Chapel Hill and more importantly, for those of you who know the staff here in Kinston, to stand up. We could not have done this without our staff, many of whom are over on that side of the room. When I did occasionally speak with a study participant about their participation in the study, I heard very good things about our staff. So it's nice to see so many of them here. All right, so I'm going to talk about the lifestyle study. And our overall goal in this study was to improve diet and physical activity to reduce the risk for heart attack, stroke, and other chronic conditions. And to achieve this goal, we wanted to offer the lifestyle program to 350 community residents, many of whom are here. But we also wanted to support and develop community-wide programs to improve diet and physical activity. And Stephanie mentioned some of those, including the restaurant program, and perhaps some of you read the articles that we had in the local newspaper. So I'm going to tell you a little bit about the lifestyle program. Those of you who were in it know these phases, but we started with phase 1, which lasted for 6 months, and this was for everybody. And our goal was to try to get people to improve their eating and physical activity habits. And we did this with 4 either individual or group counseling sessions. And then at the end of this 6-month period, we invited participants to take loss in a weight loss study if they wanted to, or to stay in what we call the maintenance of lifestyle intervention, which lasted through 24 months. Phase 2 started at 6 months and went to 12 months. This was our weight loss phase. This was for individuals who had a BMI of greater than 25, and that means just a little bit overweight. That's a BMI of 25. 16 weeks, the program lasted 16 weeks, and we offered it in 2 formats, either weekly group sessions or 5 group sessions and 10 phone contacts. And then after phase 2 came phase 3 for the last year of the project.
Would you like to tell everybody what the BMI and body mass index is?
Correct, that's a body mass index greater than 25. And then for phase 3, which was what we call the maintenance of weight loss program, for those who lost 8 pounds or more, they could take part in this maintenance of weight loss program. And for the rest of the people, including those who started the lifestyle study, we continued with the lifestyle study through phone calls. And the maintenance of weight loss participants were divided into 2 groups, and some got more phone calls than others. So what were our goals? Our diet goals, they sound simple, but it's hard to make lifestyle changes. Our dietary goals were to improve dietary fat and carbohydrate quality. And what do we mean by that? Well, for dietary fat, we know that nuts and vegetable oils are healthful. They're high in fat, but they're healthful. And so we tried to get our participants to consume more of those foods. And then carbohydrate quality refers to fruits, vegetables, and whole grains, or what Grandma told you to do. And this diet turned out to be very much like a Mediterranean diet, and why that's so important is after we started this study, a very large study was published. Many consider it the most important study published in 2013 that showed that a Mediterranean-style diet, which was essentially what we were testing and working with in Warren County, was associated with a 30% reduction in heart disease risk. That was heart disease and strokes. So diet matters, and the Mediterranean diet is probably the most scientifically informed diet, and that's what we were trying to do here in Lenoir County. And we also invited people to be more physically active, aiming for about 7,500 steps per day or 30 minutes on at least 5 days of the week. And how are we doing with the sound? Can you guys hear me? Okay. So who took part in the study? We had 339 participants. The average age was 56. 65% were African American, 77% were female, 56% had high school or less education. As we know, high blood pressure is common here, and 86% had high blood pressure. When we started the program, participants were eating about 3.4 servings of fruits and vegetables per day, walking about 91 minutes per week. The BMI was 36, and the systolic blood pressure in the lifestyle study, a little lower than in the blood pressure study, was 135. Next slide. So in terms of the first 6 months, we had 4 visits, and attendance was 86, 75, 70, and 67%. Pretty good. About 40% elected to be in group sessions, and 60% individual sessions. And then our follow-up at 6 months was 74%, and that's pretty good for these kind of studies. So here are the main findings. We assessed diet by an overall diet quality score, which increased 4.3. Based on the work that we've done in other studies, this was a large increase. So I say meaningful change, yes, and large. The types of fats that are healthful were assessed by this questionnaire, and the fat quality score also increased meaningfully. Walking time increased about 64 minutes a week, almost doubled, not quite, and that's a meaningful change. Systolic blood pressure went down 6 millimeters of mercury and diastolic 4 millimeters, and those are big changes, almost equivalent to taking a blood pressure pill. So we were really happy to see that. And although this was not a weight loss diet during the first 6 months, the diet was aimed at working on healthy types of food intake. Individuals lost on average about 1.5 pounds, and so that was good to see. This is my last slide, I think. So speaking of weight loss, I now want to introduce our weight loss expert. She too was a graduate student of Alice's, Dr. Carmen Samuel Hodge, and we've had the pleasure of collaborating for about 20 years, ever since our kids were little babies. And I'm going to embarrass her. Her oldest daughter played on the Olympic basketball team, and we got to root for her.
Volleyball.
Thank you. Thank you. Before I tell you of some of the outcomes for the weight loss part of this study, I'd like to again acknowledge the group leaders and the phone coaches for the weight loss study. Can you stand again so we can say thank you? The results I'm going to present are not only their work, but the work of the participants who really did the heavy lifting. You did the work, but you did it with the guidance of your group leaders and your phone coaches. So we have an option for you to take to be a part of a weight loss program if you want it. And Tom described this earlier, so you can either choose all group or a combination of group plus phone. So who chose what? Pretty much half of you said, okay, we're going to stay with that lifestyle program. We're not going to choose to lose weight. And then the other half was split between a small amount who said we're going to do group only, and then around 81 of you said we're going to do the combination. As you can see, that's okay. As you can see from the slide here, most of the participants in the weight loss study were African American females. Okay? And the average weight was a little over 200 pounds, all right? So what did we find? So these are the results for the group only.
the people who showed up to those who were given the program with 16 sessions. I don't know if you can see it, but right up there in the corner it says on average you attended 9 of the 16 sessions. Okay? The average weight loss at 12 months, which is when the weight loss program ended, was 7 pounds. But what's interesting to note is that you started losing weight before the program actually began, and the people who started at a lower weight and attended more sessions lost more weight, okay? So if you showed up and you did the work, you actually had better outcomes, which is good. All right, the next group was group and phone, so this is combination, and in this group, there were 15 sessions, and on average, people showed up for 10. Again, not bad. The weight loss was a little bit less, 4.6 pounds at that 12-month mark. And in this group, you can see at the beginning, nobody was losing weight. But then once the weight loss program started, the weight started to come down. And again, if you showed up and you did the work, you lost weight, right? So how did we do relative, question?
Sure. The men lose weight faster.
The question is, did men lose weight faster? Is that what you're... Okay, actually, the best losers, the biggest losers, were African American women and white men. How about that? Good question. Thanks for asking. So in terms of how well did this study, how does this study compare to other studies that involve participants that are somewhat like you, okay? So what I've done is I've put a mark here with the worst outcomes from studies that have similar people like was involved in this one to the best outcome. So and for this study, the weight loss was the group only was 7, the group plus phone was about 5. The worst outcomes, actually there are studies where people were in weight loss programs and they actually gained weight. That wasn't us. So we're somewhere in the middle, but the best outcomes are up here around 15 pounds, okay? So that's what we're shooting for the next time we come back to Lenoir County with a weight loss study, okay? We're shooting for this one. And then in terms of the folks who lost at least 11 pounds, the reason I'm mentioning 11 pounds is 11 pounds is about 5% of the weight of the average person who started in the weight loss program, okay? And 5% is considered clinically meaningful, which means you get a lot of health benefits from losing just that amount of weight. And so what did we find for our study? Again, this is us. The worst is 8% of folks losing that amount of weight. So we were right there around mid-20s. And then the best is 48%, okay? So we didn't do bad at all. Really good. And in terms of just showing up for the sessions and staying in the study all the way to the end, we did really, really well, okay? Again, the worst in terms of attendance is 33% of sessions attended, and we were right there sort of in the middle, and the best is 72%, okay? And then for folks staying in the study, the worst is 59% of folks staying in, and look at how well we did, okay? Really good. So, you can all give yourselves a round of applause. You did really good. We also had a weight loss maintenance study, and Tom mentioned that earlier. About 30 people qualified for that. You had to lose at least 8 pounds, and 27 participated. We don't have all the outcomes from this yet, but in the next slide, I can show you something that's really, really positive as well. In general, every year Americans gain weight. And on average, they gain about 1 pound a year. So what we found at the end of 2 years is that folks in the lifestyle study, about 45% of them weighed less than they started. That's really good. But then in our weight loss group, 60% for the group only, and 51% weighed less than they weighed when they started the program. Good news. And then in terms of the people who lost about 11 pounds or more, you can see again, group only that had the best outcomes, and in studies that are similar to this one, the average is 20%. So we're above the average, okay? Yeah, yeah. Okay. All right, next slide. And in addition to losing weight, if you lost weight and you weren't healthier, who would care? I wouldn't. So you lose weight, you should get some other things along with it. So in this case, what we found is that at the end of 2 years, and I think Tom mentioned some of this, systolic blood pressure improved and it stayed that way. The diet improved and it stayed that way. Physical activity didn't last, so an improvement that were made at 6 months, they sort of fell by the wayside. So we got to work a lot on this one. So in general, what we can say is our weight loss study worked reasonably well. And what we want to do is, remember we had that line with the best outcomes over here? What we want is for studies like the one that we did to get the best outcomes. We don't want to hang around the middle, we want the best outcomes. And so we still have a lot to learn about how to get there. And in terms of the lifestyle study, again, sort of the same thing. The diet improved and it stayed that way. Physical activity fell by the wayside. Blood pressure improved, stayed that way, and a little bit modest weight loss. So again, both of those studies worked really well. So where do we go from here? I guess we'll use this information to get more money to come back and do more studies. So that's the plan, because we have a lot to learn. We really have a lot to learn about getting the weight off and keeping it off, okay? I think that's it for me. Yep.
All right, so I'm the anchor man for the science part, so I will be pretty brief. I just have 5 slides to share with you, just two important pieces of data. I'm going to talk to you about study 3, which is the genetics component of the Heart Healthy Lenoir project. My name is Jonathan. I'm a molecular geneticist, so I'm very interested in your DNA. And I'm trained as a biochemist, so I'm very interested in the things that modify your DNA that is a result from your environment. So what we're trying to use this study for is to model how things like in the environment and your DNA, as well as all the risk factors that we talked about, contribute to your overall cardiac health. So the main question is, can we better understand why some people respond differently to an intervention? So what I'm talking about today are things we call SNPs, which stand for single nucleotide polymorphisms. Essentially, all of us in this room are about 99.9% identical if you look at all the different letters that make up our DNA. There's that 0.1% that gives us our skin color, our eye color, skips a nice head of hair, and my increasing forehead. Right? That's just 0.1%, right? So, go back to that one. That's okay. So the question is, we know that some people, when they do these interventions, you can't see it over here, but their blood pressure might go down, and this person's blood pressure might go down. But this person's blood pressure, who has a different DNA base here, might either stay the same or even go up, right? So we're trying to understand, can we identify these regions in your DNA, and can we learn something about that we might be able to develop therapeutics or better understand why this happens in some people versus others. So taking Jackie's bucket analogy, I'm going to focus just on the African Americans that participated in the hypertension study. And so we measured about 760,000 of those SNPs in the African American population that participated in the study. And what we found was, and then hit the button again, and we looked for those, and we were scoring it based on whether they dropped their blood pressure after 1 year in the program. What we found, now this is pretty cool. This is called a Manhattan plot because it looks like the skyline of Manhattan. Okay, these are your 22 chromosomes. We have 23, but we don't count the sex chromosomes here. So here are your 22 chromosomes, and here are the 760,000 things that we measured. And what we look for, if you hit the button twice or once or twice, there we go. We notice these couple peaks here are the individual SNPs that are associated with people that actually lost the most blood pressure. Right, so we're in the very early stages of this because I had to wait for all of this complete to do this big association. But now we can study these genes, figure out what they do, and maybe learn a lot from that. Okay, so we go to the next one. The other thing I'm going to talk about is, that was measuring a million things. Right, another way to do it is to be very targeted. So everyone knows people that love green vegetables, and we know a lot of people that hate the taste of green vegetables. And a lot of it, the last couple of years, we found out has to do with the receptors that are on the back of your tongue. Okay, and there we go. So we know that they are these receptors that sit in the back of your tongue, and there's a particular receptor that confers a bitter taste to green leafy vegetables. So if you have a certain collection of SNPs on that receptor, you perceive green leafy vegetables as very bitter. And so when we looked in Tom's study, in the lifestyle study, and we just looked at the 6-month data, we noticed that the participants that had the SNPs that did not have that bitter green vegetable taste, they increased their vegetable intake over those 6 months. Not surprising, the ones that either had the semi-bitter or the bitter taste, the sour grape looking face when you eat some kale, they increase less. And in a different arm of the intervention, those semi-bitter tasters or the bitter tasters even decrease their vegetable intake. So this is a really kind of novel and exciting concept that in the future we may be able to have a really quick and easy genetic taste bud profile that we could perhaps kind of tailor dietary interventions to suit your taste receptors. Okay, so that's another little snippet of what I've been doing. So we have a lot more work to go. Hit the button a couple more times. I still have a lot more work to do. I just talked about the data about the African Americans. I have a lot of work to do in the Caucasian data set. I have a lot more work to do in the lifestyle association studies as well. But we are working hard, and over the next year we'll have a lot more exciting data to come. So I think that is the end of the science part. So Alice, come back up and we move on.
Pleased that we have 4 folks who are going to be speaking tonight to give you a little bit of idea of what their experience was with being in the project. So the first person that we have, she's a retired health educator. Currently, she owns her own business, and she's working in the community development cooperative. Help and homeless vets get support and housing. And so I believe a Lenoir County native. And so we have Susie Sutton that's going to speak for us first.
Be sure to hold the mic close to your mouth so we can hear.
And we're going to be turning the lights on also.
Good evening. Good evening. Thank you all for coming out and to enjoy the service on today. I started in the study back at its inception in the lifestyle program, and I have truly learned that eating a healthy diet and exercise is a lifestyle that has really helped me, because when I started in the program, I was weighing 200 pounds. And after 1 year, I had lost 30 pounds. And the second year, and at the end of the second year, I had lost an additional 10 pounds, and I am maintaining. I started out with high blood pressure. I no longer take blood pressure medicine. My doctor said that I was pre-diabetic, whatever that is. One doctor said there's no such thing as pre-diabetes. You're either diabetic or you're not. I no longer take diabetic medicine. My cholesterol came down tremendously. It's not where I want it to be. But my doctor told me on yesterday that my good cholesterol is so high that she's not worried about me. I enjoyed working with the nutritionist because I was in a part where I went through the program and the telephone calls. And I would get a phone call every morning after breakfast. I weighed myself every morning. And most of all, I exercised. I did something every day, 7 days a week for at least 30 minutes. And I know without a shadow of a doubt, lifestyle is the key.
Our next speaker, she is a nurse and she works at Lenoir County Hospital. She wanted me to mention she's a UNC graduate and also a Lenoir County native and lives here in Lenoir County with her family. If you'll give a warm welcome to Kay Turner.
I first learned about Heart Healthy Lenoir through the hospital, and I was very interested in participating because one thing, I'm very interested in health promotion and disease prevention. But as Jazz mentioned, I was born and raised in Lenoir County, as were my parents and their parents, and so my generations past have been here. And there is a history of cardiovascular disease in my family. So I felt that I was a target population for several reasons. I have some of the things I have learned. I felt like being a nurse that I did know a lot of things about health promotion and how to manage my high blood pressure, and I do have some cholesterol issues thrown in there. But I think that meeting with my coach, it really helped me to analyze what I was really doing. It's kind of like Weight Watchers, you know, in a diet. You know what you're supposed to do, but you don't always do it. So meeting with my coach and having those specific things brought to my attention, you know, I started watching my salt, my sugar, increasing the beans and the fish, and making small dietary changes. And now I'm very conscious of those things on a higher level now than I was before. I think the biggest thing, which I noticed on one of the slides, was about the healthy fats. And I was always, you know, watch your weight and that kind of thing. And I was always like buying fat-free diet dressings, fat-free mayonnaise. And so I decided, you know, and I was like, can I really do that? It's going to make me gain weight if I start getting all that fat stuff. But I did because they kept telling me that was the right thing to do. And I know with, you know, in healthcare, things change, recommendations change. And so I felt like maybe I could learn some things. And so I tried it, and it has not made me gain any weight. And I will say with my cholesterol issues that my LDL has come down, and that was one of the discussions that my physician and I were having, you know, whether I should be on something for cholesterol. But it has come down, and that's really what I attribute it to, because I've had made really no other changes except that. So I was thrilled about learning that, and it has made me much more aware. I've been super impressed with all the coaching, the organization, and the whole thing. And I hope it really does help Lenoir County and Eastern North Carolina for my future families.
Okay, so our next, I wanted to say contestant, but I know that's not our next speaker, to say she's enthusiastic about her participation in the project would be an understatement. She's also a Lenoir County native and has worked at Caswell for 31 years. And so please welcome Shirley Franklin.
Good afternoon. You know, it's so good to be here and everything like that. And, you know, being in this program, I learned a lot of things. And I learned that I have another type of thing that I need to do. And when you put on your clothes, you know, in the morning times, you know, certain things you have to put on, ladies, gentlemen, you know, things that you have to put on. But I got another thing, a tie that I have to put on every day. I don't leave the house without. Even if I go to work at night, I got a loud voice sometimes. Even though if I go to work at night, I got this on. And this is my speedometer. I have been wearing it ever since they gave it to me. Ever since they were, when I go to bed. And this is something that I wear all the time. You know, a lot of times if I'm not stepping, I'm surprised I'm not stepping now because I'm always stepping at all times. My highest amount of stepping that I have done in one day is over 60,000 steps. My least amount is 20,000 steps. So I'm right steady stepping. I'm stepping. I work at third shift at night at Casual Center. I'm stepping. I'm at church, I'm stepping. I'm stepping in the choir, I'm stepping all over. Even the service, I am stepping. I have stepped so much until sometimes my mom said, I wish you stop stepping while you're cooking because you look like you stink. I said, well, I'm stinking up the Lord then. And everything. And a lot of times they said, well, you look like you got to go to the bathroom. I said, no, I don't have to go to the bathroom. But I like you got music in there, music, you hear it. I said, ain't this music up in the air? I said, to God be the glory. I said, I'm stepping for the Lord. And but I just want to say, it's an excellent program that I was in. We ended up, we was kind of like big happy family when we met every week. We cried a little, we laughed a little, we played a little. We just had a good time. And I really enjoyed being in this survey and hope to be joining y'all some more. Thank you.
I told you she was enthusiastic. Okay, I'm pleased to introduce Roberto. And Roberto lives with his family in Grifton, and they own a farm wholesale flour business, and in spite of working 100 hours a week, he managed to participate in our project, and we're so proud of him.
Thank you all for the study. I can't tell you how grateful I am. It definitely changed my life. Most important thing is Janice was always there with that phone call to ask how I was doing. Also, Jim was there all the time. I didn't have a chance to meet him yet. But those phone calls, that accountability, meant everything to me. Making sure that there was somebody there to check up on me, to say, hey, how are you doing? Are you doing what you're supposed to be doing? This program also introduced me to parsnips, turnips, rutabagas. I never knew what they were, never had an idea what they tasted like, and I'm absolutely amazed with how good a roasted vegetable can actually taste. I have lost 48 pounds. I went from a size 42 jean, I'm wearing my 34s, and it's been a long time. I can't thank you enough for what this study has done. And I know that it takes consistency, but most important to me were those phone calls I received. There was times I used to duck Janice and call me. I knew I didn't do what I was supposed to do that week. I knew I didn't. Sometimes my treadmill looked more like a rack for drying clothes than a treadmill. And I knew I wasn't honest, but I knew I had to answer that phone call because guess what? I was going to get it again and again until she heard it. No matter what was happening in my life, there was no excuse that she was going to hear from me. And it's the same with Jim. They were going to call consistently. That meant everything. That accountability, that making sure that I didn't want to have to duck that phone call because I had to talk to them. Because they were going to hound me and my phone was going to ring and ring and ring until I got back to them. So I just knew right away, get back to them. Be honest. When you didn't reach your goals, they're going to encourage you. And they did. They never sat there and said, hey, you know, you're not doing what you're supposed to be doing. They just encourage you to do better. Because there were those times in those weeks that I just couldn't do better. But they were there. So I'm very grateful that they were there, and the people that were there behind them, encouraging them to make the phone calls because they didn't always get the right answers. And thank you. Thank you very much for always being there. Thank you for holding me accountable to make sure I was doing the right thing. And I'm grateful that I was able to. And I hope that this program works for everybody that was in it. And I hope everybody learned something. Thank you very much.
I'm not sure what's next.
I wasn't either. Back to Jackie, and we're now going to have one of the physicians that was involved in the hypertension study come talk. the phone thing that you just talked about, the accountability, when Dr. Little over there called me, it was like, uh-oh, and he's got my cell number. So I feel like the same kind of human touch and accountability definitely reached us, because we asked his practice to do a lot of work, and Ed did it. He didn't just do that work. He then went around in North Carolina. He's on the line here. He went around and told the rest of North Carolina about what he did. We did a hypertension evidence academy in Greenville. We talked about hypertension with everybody in the state beyond, and Ed came, and shoulder by shoulder with me. What I've never told him is he reminds me of my big brother. So I'm the baby of 5, and my big brother Warren, oh, okay. Ed reminds me of him. So it's just been a blast getting to work with him all this time.
When Jackie first asked me to speak about my experience in the study, I thought it was quite a challenge. How do you boil down 4 years of study into a several-minute speech? I think the best way to do that would be to share with you the most important thing that I learned participating in the study, and why it's important, and how that came about. What I learned, most important, is in order to make a change in somebody's health, you have to make them an active participant in the process. The study directors were very much into that from the very beginning. They got feedback from us and from patients about what we thought the problems were, what would be ways to help change the health situation. And there were several ways that that was done. Of course, you've heard some about phone coaching. Which Jackie mentioned, I think we used a set of questions as a regular thing, and everybody that came in for hypertension to get an idea of how they were doing, get their feedback on how things were going. Probably the most important thing, though, was the home blood pressure monitors. Every patient that participated in the study got one of these monitors. And for many people, that was the very first time in their life that they could get information at home about how they were doing. And that made a big difference. I'll just tell you about a couple of people. One was a woman who, every time I saw her in the office, her blood pressure was 170 over 100. And most of you probably realize that's a whole lot higher than it should be. But once she had the blood pressure cuff at home, her blood pressure was 130 over 80, sometimes less than that. And it turned out what it was, she just was very, very nervous coming to the doctor. And there's a lot of that. They even have a term for it, white coat hypertension. And the only way for a doctor to really know how the patient is doing is for them to get the blood pressures at home. And that works in a lot of other ways too. People who eat, well, let's say country ham a couple of days for breakfast, and they see their blood pressure going up, realize maybe that's not the best thing to eat. People who say, well, I feel good, I don't have a headache, I don't really have to take my blood pressure medicine today. When they check their blood pressure and it's sky high, they say, yeah, maybe it might be an important thing to do that. And I think that really was the most important thing that I learned. I think that this was a great study. I really enjoyed it. It's the first study I've ever participated in, but it certainly won't be the last. And I think it has made a big difference to Lenore County. I'd like to thank all of my patients that participated. I think there's a couple of them here. The study staff for doing, I think, just a great job. Thank you all very much.
Inspiration in himself. When we were coming just to Lenore County to decide whether we might see if we could do this study here, we visited with him in his office, and he pointed to the school building across the street and said, our dream is to turn this into a wellness center. That's what that school building is. And also Alice Scott, who's a big part of that, just that initiative and that effort, and then it's been really successful. A lot of people have participated. Just it's how these collaborations work. So I wanted to ask Joey Huff, the health department, as a public health professor. I'm a big fan of health departments and health directors, and Joey is certainly high on that list, and he's been a really important partner in this.
I'd like everyone to thank everyone for coming out this evening for our wrap-up session regarding the study that's been going on for the last several years. I can remember the opening session that we had a few years ago when the announcement was made about the grant. I think I shared with the group at the time that 50 years ago, health director at the time was a physician, and they were called health officers as opposed to health directors. Anyway, Dr. Jones was a health officer in Lenoir County at that time, and in 1955, the old health department located just down the street here was being a grand opening, ribbon cutting, because of some funding that was made available to the county health department. Dr. Jones in this article was also relaying at the time the number of flu cases and other communicable diseases that the community was experiencing. But he had the notion that the next public health concern that the community would have to address would be chronic disease, particularly cardiovascular disease. I'm not going to make a bold prediction as to what maybe our next public health epidemic or communicable disease or issue would be in the near future, but I think what has taken place in Lenoir County in these last 4 years with the work from UNC-Chapel Hill and ECU and with the funding from the NIH, so I think we're on a good track to address that issue and hopefully bring to close Dr. Jones' premonition or his comment earlier regarding heart disease. So I hope that what has occurred in our community that we have seen so far on the charts and the diagrams and the wonderful comments that people have shared with us, I think it's been so heartwarming that when you see the dots and the lines and the charts, but when you hear people talk and speak about their own personal experiences that they have gone through, brings it home and you fully understand. So I hope that the folks from NIH who are here, you can remember that and take that back and realize that the funds from the generosity of the U.S. taxpayers we're reminded of today, that has really helped and made an impact for Lenoir County. And hope that in future studies will then continue to help Lenoir County, but the rest of the residents in North Carolina, those of us who are living on the stroke belt, to live longer, more productive, healthful lives. So again, appreciate everyone being here. It's been a pleasure to work with the group and other agencies and organizations regarding this project. It's a new experience for me, and I really appreciate the opportunity for those who conduct research to come back to us and share with us the outcomes of that. So many times I participate in surveys or other research opportunities and never hear a word about what has occurred or what the results are. So I appreciate that opportunity. Thank you.
Thank you, Joey. We're getting close to ending time, but I did just learn that we have one of our political leaders in the audience tonight, Senator Davis. I would be interested in. Would you like to say a few words? Or not to put you on the spot, but campaign. Exercising on the way up.
I'm telling you, after the inspirational stories, it seemed like everybody was moving up, I think partly to keep us on time, but also we're monitoring our steps. But I've learned a whole lot today, and I want to commend this community and everyone who's been a part of this study. Truly, this is just an awesome story that we need to continue to share and engage and learn as we grow in terms of our research. But some of the takeaways, if I'm at church and I see someone in the choir doing this, I know what's going on now. I also understand when I have problems with my kids eating the greens with some of the genetics that's going on, but still make them eat it. But no, seriously, thank you for your participation in the study. Thanks for your commitment, and to all of those primaries who've been working to bring this information forward. I really came in today just to get a picture of the information. This is just an awesome, awesome story. So thank you. One other thing too, I think someone asked to recognize UNC. I have to, as a graduate of ECU,
I'm not sure if we're going to be kicked out of the building or not, so we have a little more time. So if anybody else would like to share anything? raise a question about jeans and kale?
Well, I'm going to ask the doctor,
What was that?
Did you lose the weight?
Yeah. About 5 pounds.
Anyone else who'd like to share anything? Yeah?
I just have really a question. In talking about the change in eating habits, could you comment on what's available locally from a vegetable or a fruit perspective? That sweet potatoes, muscadines, a variety of things. Could you comment on some of those ideas?
Is Tammy still there? Tammy, head of the farmer's market, and wants some other vegetables. I agree with everything she said.
And while we're talking about school, I'm at the state, so go Wolfpack. Obviously, I know if you're talking about agriculture, right? We have a lot of fruits and vegetables locally available. Certainly, strawberries are about to come out, so that's one of the highest fruits you can eat for antioxidants, and it doesn't really hurt your sugar too much. We have corn, soybean. The biggest thing that I've noticed, I can't forget to go on. I know we already have greens, including spinach, at the market right now, and some kale even, believe it or not. It's about time for asparagus, so that's what's coming up next. But the biggest thing with our producers is that if you find a product that you think you would like to try, we have a couple projects going on that will, one, try it, like with cilantro and different herbs, and two, the same thing with vegetables. So we have actually increased production in spinach and kale and a lot of other healthy greens as a result of the purchasing power of the customers. Certainly muscadine's full of antioxidants as well, and I know that's where he's getting them. Carolina Wild. Yes, ma'am.
I just want to ask, isn't it better to eat more organic because a lot of the...
I mean, it's not necessarily that much better. Some people are leery of the pesticides that are used, and it just depends on where they were produced, and that's why
Even with the meats, there's a lot of...
we're talking about antibiotic-free meats. Natural meats tend to be a little bit higher in taste and fat just because they are fed more naturally, generally. Can't say that overall forever and ever.
High production, you know, they use a lot of...
Excuse me?
For fast production, they use meat, you know, use a lot.
Right, yeah, there's a little bit of extra hormonal injections, but not quite like it used to be. I think you'll find a lot less antibiotics and a lot less hormones injected to our mass production of pork and poultry anymore these days. Again, organics just depends on who produced what and whether they're organic. If they're not organic, you can also always talk to your farmer. That's why we promote buying local, because if you speak to your farmer, they can tell you what they've used on it, and it may not have that much pesticide that that you already think it does. So it can be beneficial. Yes,
I have a question about the grapefruit with the blood pressure. If you eat a grapefruit like for breakfast, that really will fill you up.
I've heard that.
But
grapefruit and blood pressure medication, it does not mix well. Is that? Yeah, let me give that one to a doctor. We do not have grapefruit in Lenore.
So grapefruit can interact with certain medications. There are some cholesterol-lowering medications and some other medications, so I think it is important to follow the direction of your physician. On that note, though, but please ask your doctor, small amounts of grapefruit on some of these medications is permitted. So a half per day or a small 4-ounce portion. But large amounts of grapefruit in some medications don't mix, and small amounts are not recommended. Small amounts of grapefruits for some medicines. So ask your doctor or pharmacist. I just want to say one more thing before I turn it over to Beverly, and that is the next step. One of the next steps for us is to continue to understand what we've learned, because we've collected a lot of information. We need to share it with the scientific community. We need to share it with the clinical and health promotion community. And we also need to share it with you. So I don't know if we're going to convene as a group together again, but I do know that we plan to send out another newsletter down the line when Jonathan has had an opportunity to gain more insight into the important work that he and his colleagues are doing And when we have a little bit of a better understanding about what worked and what did not work in the lifestyle and blood pressure studies, we do plan to share that information with you.